very much. My name is Roseline Mkabana. I work with Nairobi County Health Government. I head the Gender-Based Violence Unit, and also I am the Chief Medical Social Work. What I do here is ensure coordination of psychosocial and GBV services within Nairobi County, and also provide support to the medical social workers within our health facility. Given the two roles, I am mandated to ensure that we provide prevention mechanisms, support systems, collaborative systems within other non-state and state actors to ensure that we reduce cases of sexual and gender-based violence within Nairobi County. My unit has been there way back now. It's almost 10 years when it was formed. And during COVID, we really had to undergo a lot of challenges because it meant working from home. And provision of psychosocial support for any person who is undergoing matters that are associated with mental is very challenging, in that sometimes it's important to have a face-to-face direct communication for you to be able to get exactly what this client is going through. So for us, when COVID came in, we had a lot of clients who needed to talk to us. But remember, for us, we were working from home. And it was not easy for the vulnerable members of the society, more so coming from the slum areas, to be able to even call me and tell me these are the challenges they are having, considering that they were also suffering on issues of not even being able to have a meal because of the time of the curfews that we had. And so matters mental health, matters gender-based violence were not considered. So we have been there, and we have provided that support. And yes, we can. We did a lot of collaboration with those who are on the ground. When Corona came, we found the issue of curfews actually escalated the problem. And there are some spaces we never thought were safe until COVID came. And these spaces are places like schools, places like people even going to work. And that is when we noticed that when you're at home, a house can be very crowded. And when it's crowded, there are a lot of issues that will go on that will lead to a lot of quarrels, and later on it leading to what we can call something like intimate partner violence. Our girls were not spared because we had a high increase. During that time, the 2018-2019, we were by then only having about cases around 2,000 coming to our health facilities. But we noted after COVID, when we were doing our data, that we did have high number of cases. But remember, even coming to our health facility itself was already a stigma, because someone would be associated, you're going to the hospital because you have COVID. So the numbers that were coming to our hospital were limited, but the cases that we were receiving by phone from the community on issues of gender-based violence were very high. The highest number of cases that we got at that time had to do with incest. Fathers and their daughters, brothers and their sisters, and then of course the in-house parties that we all had that were going on during this little time that the adolescents, especially I'm talking about the adolescent because that was the biggest challenge that we had. So those are some of the cases that we had to walk through. And now one other thing that became a big challenge is the provision of medication. How are they going to get their medication? And how are they going to be even, you get a case, how do you report it to the police? Everybody is scared of going out. And that's how we were able to come up with a small structure together with partners and do what we were looking at, prepositioning of medications, prepositioning of safe facilities where these clients can go to, and also ensuring that they are provided with the minimum package of care despite not having our facilities. In Nairobi County, we actually were decided that we are going to use some of our health facilities as part and parcel of our safe spaces. And a facility like Mama Lucy Kibaki, where we have what we call Tumaini clinics. If you look at our directory for Nairobi City County, or you Google in our website, we have what we call Tumaini clinics. Why do we call them that? We call them Tumaini clinics because because of restoring dignity to survivors of sexual violence. By that time, we had only about 6. That was Mama Lucy, Mukuru Health Center, Kasarani, Dandora, Mbagathi Hospital, although Mbagathi was not working at its full optimal. And then we also had private facilities that we also looked in, and that was Mata Hospital, where we had an agreement with them and agreed that in case they have any cases of sexual and gender-based violence, they would be able to provide services without payment. And we also worked with Coptic on the same. So we looked in, and because Nairobi Women's is known for providing services to survivors of sexual violence, it was easy sometimes for them to go there. And at the same time, we worked with organizations that partnered with us, and that is like MSF. With MSF, we agreed to have on standby ambulances as site facilities in the ground, more so in places where we had very high numbers of COVID. We were able to place ambulances within their places and ensure that the ambulances were stored with medication, and we were able now to work on shifts. Us as even healthcare workers, I get a clinical officer, a social worker, or a nurse, and a counselor to be able to provide these services. If the survivor is not able, we were also making trips to the home. But the problem again we encountered when we were doing this is we remember there was the siren. When anybody hears a siren coming or an ambulance being seen outside anybody's gate, it was immediately known that this is a COVID case. So that meant again that house needed underwent a lot of stigma and discrimination. So we had double work of trying to convince the community around it that these are other issues, and then also even taking the perpetrators to go to police was also a challenge because the police also were not ready. And COVID came in with all of us had our own myths and misconceptions on how it spread, on how it is to be taken care, how it's taken care of in terms of medication, or how are you getting infected. So anytime where you saw someone and our ambulance was seen or our partner ambulance was seen, those were some of the challenges that we underwent. And formation of community structures helped us a lot, in that the use of toll-free lines was one of the guiding factors that helped us. And also just to ensure that the cases that were very, very bad, we actually agreed with our facilities that we would actually allow them to stay in hospital to reduce visitors, so that even when they're at home and they're on medication, someone can be able to track them well. So those are some of the issues that we were able to work with. In the GBV programming, I have had to be able to come up with structures within the community. I have what you call GBV defendants. Some of them are women who have also undergone violations in one way or another. So we have formed what we call community technical working groups within the various sub-counties within Nairobi County. And then I have the social justice system. The social justice system encompasses teams of paralegals that we have been able to take them through, for them to be able to be guided on how to track sexual and gender-based violence cases, to ensure that they link them up with the police, pick up the cases and ensure that the cases go up to prosecution level. And other than that, the paralegals are guided also that they can be able to ensure that when the cases are in court, they're able to remind the survivors when to go to court. And then some of the social justice systems have been supported, whereby they're also giving transport to the survivors to go and collect, for them to be transported to go for cases when their hearings are coming over. Other than that, we also have male engagement, groups of men that we also worked with to be able to support us in this framework, so that most of the time men are seen as perpetrators, but we were looking at a situation where we're looking at men as protectors and not as perpetrators, so that they can, their role majorly was to ensure that they are able to pick up some of these cases and be able to talk also to the men to ensure that we reduce the number of cases that we were having, and also just look at what are these societal things that are causing men to go over and beyond what should be as a man, where you're a father and you're looking at your daughter as your wife, and how do you be able to support your family. so that the issues of intimate partner violence don't even come in, considering that we are all in one house for so long. So that was also a very big challenge for us. And then, other than also having male engagement, we had what we came up with as survivors of sexual violence. We call it Survivors Network. So the Survivors Network acts as a peer. So they were also able to support us in following up cases of survivors who have undergone sexual violence or gender-based violence, and work with them as peers in the situation where we were not getting immediately counselors or psychologists to be able to walk them through as a peer-to-peer. So those are some of the structures that we have in. And other than that, we also used our safe houses. But the safe houses that we have in Nairobi by then were not manned by the county government. We do not have our shelter of our own. But now, within the last 1 year and a half, we've been able to come up with one. So the shelters that we had, through the National Gender and Sector Working Group, we were able to support these shelters by giving them a fund, and for us looking at survivors and supporting them with food baskets weekly, and providing them with a stipend of 6,000 shillings to be able to take care of themselves, and also themselves as survivors of sexual violence, and also to look after their family members. Because sometimes you'll find some of the caregivers who are undergoing violations are also mothers, and they're also daughters, and they are people who by then didn't have any work. So those are the systems and structures that we had in place. We actually gave them 6,000 per week for 6 months. Yeah, supported through Oxfam, CRU, and Wango Kanja Foundation. And what we did, we asked, I'd forgotten to say, we also have, like now that I head the SGBV unit at the county level, I have a structure of SGBV focal persons within the sub-counties who now are able to cascade these services within, collaborating and coordinating these services at the county level. So we asked them, they're the ones who knew the survivors who had come to our facilities, and they were able to recruit them for us. And we were able to actually vet them, because one of the things was you had to have undergone sexual violations. You had to undergone at least one form or the other of gender-based violence. And talking about gender-based violence, we're only not talking about sexual. We're talking about physical. We're talking about emotional. We're talking about economic. We are also talking about, in quotes, I don't like using that word, what we are calling child marriages, because child and marriage should never be in one WhatsApp group. There's no way a child should ever be in a marriage. So, but then we had those cases. And these were some of the cases that, after that, we found out that we had very many cases of adolescent pregnancies. And again, because ARVs were being given after 3 months, our infection rate for HIV also just went up in that manner. So we had quite a number of adolescent girls who got pregnant. For the girls, it was even worse. When you look at a place like Kibra or one of our slum areas, whereby you have to use public toilets. These public toilets are paid for. When the children go to school, the parents don't have a budget for the toilets. But now when children were at home, it meant that parents had to pay even for use of the toilets within our slum areas. So that added another burden. So for our young girls, getting just 10 bob or 20 shillings to go to the toilet, and you get a boda rider who's ready to give you 50 shillings for all your people for a 1 minute stand of sex. That is how many of our young girls got now involved in getting that, because of the use of toilet and bathrooms. And then the same also goes for the issue of sanitary pads. And one of the things that some of our partners came up with was also provision of sanitary pads. But again, it meant that most of the people who were requesting, if we could, most partners had not budgeted for dignity kits. And we noted that even as we were giving them, you take to a family a dignity kit that contains toilet soap, tissue, it contains a toothbrush, a toothpaste, and it contains also maybe an underwear for a girl and boy, and Vaseline. Now the parents were finding it better. Now you take them a dignity kit, they sell the contents and now remain with the sanitary pads for the girls. So that again brought in for us to the community, and we found that they found a better use of more than we thought was needed at that particular time. So those are some of the structures we had in place, and also we had reporting mechanisms. The community is able to report to the sub-county GBV focal persons of a case that has happened and maybe has not accessed the hospital. And then for us, then we are able to send an ambulance to go and pick the survivor. But remember, sending an ambulance is stigmatizing the community, because to them already owed him to a COVID. So we had again to find a better way. How do we do it? So we worked again with the community. Now we are calling them community health promoters. By then they were the CHVs. We call a CHV who has undergone training, send them to that specific, give them the contacts, they go to the house, tell them to walk to a certain distance, and then we will be able to collect the survivor from there. What was the risk there? The risk was loss of evidence that was to be collected, evidential material that would be collected to a case. So that proved again a challenge for us. I remember one time I personally had to move from where I stay and tell a caregiver, bring that survivor to the facility where I was. And by then I told them, well, let's meet at Umoja Health Center. But when the child was being brought to us, we noticed the fact that they walked for some place to where we had lost a few evidential material that would have sustained for us to keep up that case as it goes to court. So those are some of the challenges that we underwent. And even you remember that time the court cases were not going, courts were not sitting. So we had a backlog of quite a number of cases that we had to deal with. And despite the high number of cases that we had, if I remember very well, I only had about 18 cases that went to court. And out of the 18 cases, only 2 were able to go up to the end of the prosecution level, where were able to sustain a conviction. Initially, if I look at it also, we also had to blame us as the healthcare providers, because maybe our documentation was also not good. Collection of evidential material, survivors and caregivers not wanting to come to go to court because maybe they know the perpetrators, so their lives are also at risk. The attitude of our police service then was also not, I don't blame them, because COVID was very new to everybody. So everybody was looking at how best to prevent themselves. So they will tell you, kama ni kitu kama rape, hiyo ni kitu mtaenda msikizane nyumbani. Ni nani ni baba? Nawe mama, sasa ukikataa, sicha pesa yako ya nyumba itaisha. Endeni msikizane. So they would send away. So the police officers now became the judges, the jurors of what the cases had been done. And that really messed us up in one way or another. I think having been in the GBV world for more than 13 years, there's been a change in the police force. They are more positive. Their attitude has changed. They understand. And I think the fact that cases of GBV are not only focused to one gender, that they also have their own who had undergone, the attitude might not be 100%. But for me, having worked in this sector and the collaboration and the work that we do together, there's been a very big change within the police force. And other than that, the National Gender and Sector Working Group, they are part and parcel of that group. And we have cascaded it, like I had said earlier, up to the sub-county level, where they also sit in those committees. So we allow them to come and we allow the teams to come and bring in their complaints when a case has not been handled well. They also come in, and then also working with the girls, the chiefs. In fact, sometimes I feel even the chiefs do us more injustice than even the police, because the chief is the first person where a survivor of GBV will go to, and the chief knows everyone.
Yes.
So the chief will be like, madam, kama mzee alikuja amechelewa na akakupiga tu kakofi kadogo ndio inafanya unapiga kelele, hiyo ni kitu tunaweza saidiana. Wacha tutaita mzee, and they send you back home. So those were some of the challenges that we underwent. Yes. But in some households you will find, because society and the patriarchal norms are very clear, that a man is a man should do this, a man should not do that. So, and then women tend to again hold back. But with the empowerment that we have received and the support from state and non-state actors on supporting the empowerment of the girl child has brought in a difference. And yes, we will complain and say it has also made the boy child now be a victim of circumstances.
Mm-hmm.
But my take is, when women are empowering the girls, where are our men to empower the men, to empower our boys? Because even the information that we are giving to our boys as empowerment is coming from us women. The men have very little time for the boy child. So if our men also took it up, and that's why I always fight and say, if we do not have a leadership that recognizes that GBV is a two-way, there's a boy and there's a girl. For us to make it work, let us empower the boy, empower the girl. Let the boy know why it's wrong to beat a woman. Let the girl know, I do not need to talk in a high-pitched voice for this man to be able to listen to me. We need to complement each other. And I congratulate the government, because one of the thematic areas that we were missing out in all the thematic areas of gender was the issue on male engagement. And our government currently, the other day with the Mheshimiwa Jumwa, we launched the 5th thematic area of where now we have male inclusion and male participation and male engagement in matters gender. We look at that gender lens in an open manner whereby we know men have their roles. But at what level do we then complement each other to ensure that we reduce the patriarchy that has been ongoing, and not because we want it, it's because that is the way we found our society. But we have the time to change it, and we have the time to make it better by ensuring that the boy and the child and the girl, all of them are at, they might not be at par, but they have equity in the level that the boys were. COVID taught us lessons. COVID taught us that in everything we do, we should always have a plan B. COVID taught us that there are spaces that we have assumed into our heads, but actually are safe spaces for our children and ourselves. COVID taught us that a hospital building alone is not enough, that it needs qualified staffs, it needs proper drugs, timely drugs, people who are aware, people who are ready to provide emergency services at any given time. COVID taught us that HR is very important in a health facility. COVID taught us that the community needs to work together to ensure that as a community we can be able to fight a pandemic that comes in the way that COVID came in. Remember the issue of masking. Not all of us were in a position to purchase masks. But then it showed us that we can be able, with a small working together, we can be able to support that other community. My take is, let us always be prepared for any eventuality that comes. The community should have its own mechanisms to sustain itself. We saw that we relied so much on partners, and there's something that is called sustainability, that we must work as a country and as a county. A partner can come in, yes, but we must have a sustainability plan always. Thank you.